Good day everyone, we are Group D and the current presented slide and the following slide is our given case assignment. To summarize, for the patient demographics, the patient is a 26-year-old male and had a travel history. He came to the United States from Vietnam 6.5 years ago. He lived in Arizona for 6 years prior to moving to Boston. And for the following slides and presenters, this case will be further discussed and analyzed.
Through differential diagnosis, the medical technologist could include several causes of subacute enlarging masses. Among these, some of the fungal causes that most stand out are Penicillium marnefi, a dimorphic fungus as the patient history of travel from Vietnam is suggestive of. This fungus is found in Southeast Asia and is the third most opportunistic infection among AIDS patients in that location. Coccidioides immitis, another dimorphic fungus that is also considered as the patient has a recent history of living in Arizona, which is found in the soil in arid areas of the United States, Central America, and South America that correspond to the lower Sonoran life zone. Other dimorphic fungi are crossed out as the patient has no recent history of exposure to them, such as Blastomyces dermatitis, Paracoccidioides brasiliensis, and Histoplasma capsulatum. Other causes that could be included through differential diagnosis. Mycobacterial may be Mycobacterium tuberculosis. Bacterial causes may be Actinomyces species and the Nocardia species. And finally, a non-infectious cause may be lymphoma.
Now let us talk why it is such a major concern when the laboratory technologists did not notice the presence of the mold and open the plates to examine them for bacteria. First and foremost, opening and examining the petri dish is a procedure that produces aerosol, and the laboratory technologists should be careful in opening and examining a petri dish, especially that the fungal culture is capable of making aerosol, which could be transmitted airborne and infect the laboratory technologists. The medical technologists may acquire laboratory-acquired infections with dimorphic fungi such as the Arthrochonidia of Coccidioides species. This is one of the fungal culture that are easily aerosolized and may result to deaths of laboratory workers. Secondly, using biological safety cabinets must be done. As a solution, using biosafety cabinets is important to prevent contamination and transmission of fungi. This is also specifically prevents cross-contamination of other cultures by the fungal conidial elements. And lastly, good safety technique must be done. The medical technologist must perform good safety technique. For example, all fungal cultures that are planted on petri dishes should be routinely closed with either tape or a commercially available product such as shrink seal to prevent the plates from being inadvertently opened. Additionally, the medical technologist must have the habit of observing the plates before opening them to minimize the risk of laboratory-acquired contamination.
As the figures show, the organism is identified as Coccidioides species. To discuss further, the following are the details. Here we have the macroscopic and the microscopic features, where in the latter, the appearances depend on the temperature of isolation. Our references regarding the macroscopic features of the identified species are consistent with the statement on the case, especially on the appearance of the mold, which appeared to be white. It was also mentioned in the case that there is a microscopically observed demonstration of arthrochonidia formation. And talking about arthrochonidia, they are formed during the fragmentation of hyphae during sporulation. Although there is a wide variety of species capable of producing arthrochonidia, those other species cannot allow the manifestation of the clinical syndrome under study. Next, in order to definitively identify the species as thermally dimorphic fungi, there is the need to perform the following: demonstrate that the fungus can transform from being a mold to being a yeast, demonstrate the presence of an antigen characteristic of the organism, and identify the fungus with a genetic probe or by genetic sequence. It is observed that Coccidioides species continues to grow as a mold and does not produce spherules at any temperature unless there is the utilization of an in vitro method or a special growth medium. This result is indicative that temperature is not the only key factor that allows the formation of spherules. This led to some scientists not preferring to classify the fungus as thermally dimorphic, but due to its other variables, it is most commonly classified under the thermally dimorphic group. Because the definitive identification of an isolated Coccidioides species requires the observance of spherules in vitro, use of DNA probes, and application of exoantigen tests, the mold was sent to a reference laboratory that had the commercially available genetic probe.
Good day, everyone. I am Joanne Femutia, and I will be reporting on the clinical manifestation of infection. The majority of people who have been exposed to the fungus coccidioides are asymptomatic. However, in other people, infection can cause a range of illnesses, which may appear in the first 3 weeks and last for weeks and months, depending on the severity of the infection. The most common clinical manifestations of coccidioides infections are as follows: fatigue or tiredness, cough, fever, shortness of breath, headache, night sweats, muscle aches or joint pain, and rash on upper body or legs. The flu-like symptoms mentioned are common manifestations of valley fever, since this infection is typical in the San Joaquin Valley of California, USA. Disseminated infection with Coccidioides immitis or Coccidioides poseidaceae is not usual or is less than 1 to 5% and is more common in non-whites such as the African Americans and Filipinos instead of the whites, JAF 2013. Populations in which there is an increase in the risk of dissemination include Latinos, African Americans, immunocompromised individuals, pregnant women, cancer patients, particularly lymphoma, and those taking up medicines that weakens the immune system, such as steroids, tumor necrosis factor inhibitors, and chemotherapy drugs. Although there is no known data specifically on the risk of disseminated disease in persons of Vietnamese heritage, Asians have an increased risk of acquiring these infections as well. According to the Centers for Disease Control and Prevention 2020, aside from the lungs, which is the most common organ affected, Coccidioides immitis or Coccidioides poseidaceae also involves the central nervous system such as the brain, spinal cord, and meninges, which may be life-threatening, then the skin, bones or joints, and subcutaneous tissues.
The possible explanations as to why the incidence of disease with the organism infecting the patient has been increasing are as follows: higher restrictions of the treatment due to its cost. People who migrated to areas where coccidioidomycosis is endemic, such as Arizona, California, and Mexico, and have not been vaccinated against the pathogenic agent of the disease. Poor hygiene, especially if wounds are exposed to dirt or dust. Improvement in the diagnostic or laboratory methods. Probability of misdiagnosis, misreading of results, as well as contaminated samples during examination.
So, good day everyone. Again, I am Fatima Keito Abad, and I will be the last reporter for this case analysis. So, coccidioidomycosis is an endemic fungal infection of the southwestern United States. Normally, a self-limited infection in healthy hosts, coccidioidomycosis can become a serious complication in patients who have had a solid organ transplantation. Among patients whose solid organ transplantation was complicated by coccidioidomycosis, the infection has a variety of clinical presentations. Disseminated disease is common and has a substantial morbidity. There are actually two possible explanations for this observation. One is that transplant recipients are latently infected with the organism prior to transplant, and the immunosuppression results in reactivation of infection, leading to respiratory tract infection. Patients at risk for coccidioidal infection should be identified so that antifungal prophylactic therapy can be initiated. That ends our case analysis presentation, and thank you everyone for listening.